Good afternoon, everyone. Let's wait for the others to join, okay? Then we start. All right, let's give ourselves another 3 minutes to wait for others to join. Okay, 3 minutes to wait for others to join. Can you hear me now? Let me know if you can hear me. Let me know if you can hear me from your end. Let me know if you can hear me from your end. Okay. Let me know if you can hear me from your end. Those of you who couldn't join this morning session, I said that, yeah, those of you who couldn't join this morning session, I said that I was, from next week Monday, I'm starting a new journey. Okay. And I'll concentrate on the physiology aspects. Okay. Then those who have their ATT, we focus. So the ATT class will focus on the curriculums. Okay. Yeah. We'll focus on the curriculums. Okay. Yeah. So we are going to divide ourselves into two, not by creating a new page. Okay. So we are going to have the ATT and those who are not having ATT. Okay, no ATT. So on the ATT page, we'll look at, as part of what they are doing, okay, or in addition to what they are doing, they will be looking at a curriculum as well. Okay, so they learn. Today we did clinical judgment. It's only 1 day job, then we are done. Okay, yeah, because the curriculum, you can easily catch it, grab it, and go. We want the ATT page to be more active. Okay. Yes. Then those who are not having their ATT, we will start from afresh. Okay. We're starting from afresh. So physiology. We will look at the system by system. Systems. Then we look at what the special clinics. Okay. So the special clinics, the psychiatry, the maternities, the pediatrics, the ENTs, the oncologies. Yes. So all those ones, those special clinics. Okay. Yeah. So this is what we are going to do. So at the end of the other time, I made you guys vote. Okay. So at the end of the 4 months, those who chose 4 months for the journey, at the end of the 4 months, we should be done with everything here, and you should be ready. So with that, when you get your ATT and you join, when you get your ATT and you join the ATT page, you are already a master of physiology. So when we get to the ATT and you see questions there, the way people are answering questions, the way people are explaining physiology, you will not be fumbled. Okay. You will not be surprised and shocked. As a fresh starter, we can add you to the ATT group because you'll be confused. Yes. The way people answer questions there, you will be confused. Okay. It will scare you off. So we don't want it that way. So this is the journey we are going to go from next week. Okay. For the next 3 months of next 4 months, we should be done. And when you get if you complete the 4 months and your ATT is in, give yourself a month or two. It depends on you. And you write. Okay. That's it. Not a rush. So when ATT class is ongoing, we can share the link to the main pages depending on what the admin says. Okay. If you are part of the ATT and there's a class ongoing at the main page too, we will share the link. If you want to join, if you are interested to join, cool. Okay. So that is how it's going to be. So that is it. If you are on the ATT page and you pass your NCLEX, we will take you off. Okay. But That doesn't mean we are going to take you off from the main page. You pass through the main page to enter the ATT. And if you are not part of the main page, don't try to enter the ATT page, because if you don't have your ATT, you can join. And we do so many checks too before you join the ATT page. So you have to first be on the main page before you are allowed to join the ATT page. Okay. So these are the changes we are making. These are the changes we are making. Okay. So let's continue with what our basic care and comfort. We are looking at part 6 to part 10. Okay. Not a rush. You take it bit by bit. So part 6 talks about skin integrity. If we've started this journey from caring for the sick, the basic activities of daily living, okay, yes, and all the things we need to do. For if you take the part 1 to 5, you see everything there. So part 6 to 10, we are looking at skin integrity, pressure injuries, and wound care. This is one area that NCLEX can easily fail you. You would think you know, but NCLEX can easily fail you. Okay. Why? Because they will draft the question in such a way that it will become a safety question. You think you can easily lift a patient. You think you can easily use assistive device, but when we give you the question, you will fumble. You won't know what to do. Okay. Yes. So a skin problem. In part 6, we are going to talk about skin. We are going to talk about skin. Okay. We are going to talk about the skin. Okay. So all the issues about the skin. Okay. If you look at the skin, the layers of the skin, I think I was having some pictures here. If you look at the skin, we have the layers. Okay. Yes. And it goes down. So before you can, before the bottom layer like this gets like stage 4 injuries, okay, gets or stage 4 wound gets involved, definitely the dermis, the epidermis, the subcutaneous fats, okay, yes, those one, and the deep tissues, okay, should be destroyed first. Okay. Yeah. So this is what we are going to look at today, the skin. Okay. Right. So a skin problem can quickly become a perfusion problem, infection, hemorrhage, or surgical emergency. Yes. You can get infection, you can get bone infection, and the only option will be to go and amputate you. So don't underrate skin infections, okay, or skin injuries. Why? So why is the skin integrity, okay, so important? Why does it matter? Because the skin protects all the internal structures and the external structure. It's like a cover, a canopy that covers you from head to toe. Okay. So the skin protects you from microorganisms entering your body. It is the largest organ. From fluid inside you getting lost. It protects your in the inner temperature. Okay. Yes. So if I touch, if the inside is warm or hot and I touch your skin, I should feel that reflection. Okay, I should feel that reflection. Yes. So if I want to take a temperature, I can just put it on the axilla and feel the temperature inside. If I don't want to do oral or anal or whatever. Okay. Then fluid loss, temperature, your skin will become what? Cold. clammy, yes, dry, moist, all these ones, flashing, sweating. Uh-huh. The skin also protects the internal organs from what? Environmental exposure like chemicals and all those ones. Okay. Yeah. So, yeah. So, this is what, that is why the skin is very important and that we need to know how to protect it. When the skin breaks down, the patient is at risk of when the skin breaks down, the patient is at risk of infection, pain, fluid loss, impaired mobility. Yes, you can get contractures. Okay, yes, fluid loss, impaired mobility, delayed healing, sepsis, and and in severe cases, we have severe sepsis and all those types. Okay, yeah. So these are the things. NCLEX is not simply asking you what does this wound look like. They will never ask you that. NCLEX will never ask you how does. Please give me 2 seconds. I'm coming in. Okay, so let's continue. Right. So when the skin breaks down, the patient is at risk for infection. You can get pain. Yes, you can get a wound that is paining you. Okay. Pain is a sign that a cell is destroying, a cell is dying. Okay. Yes, you can get fluid loss. So somebody has burns, all the body fluid or majority of the body fluid, okay, will be lost through the skin because of the barrier that has been broken. Yes, and the person can get hypovolemic shock and die if you don't correct it. We have impaired mobility. Okay, we have delayed healing. Delayed wound healing. Okay, the skin can break down, and there can be what eschar and all these black stuffs. Okay, covering it that can what delay wound healing. There can be sepsis in severe cases. So NCLEX is not simply asking you, what does this wound look like? No, they are asking, is the tissue perfused? It's a safety question. Okay. Is pressure continuing? There is a pressure on the skin that is pressing on the internal organs, okay, or the internal structures of the skin, okay, and destroying the skin. If I put pressure on the skin like this, I block blood coming to supply this part of the hand, and I block blood, taking blood away, vessel taking blood away back to the heart. So both the arteries and the veins will be hot, will be lost, will be affected. That area will tell you whether it is the artery that is being blocked or it is the vein that is being blocked, depending on the wound, how the wound ought present itself, okay, or the injury present itself. Yes. If infection is present, Encles wants to know that skin wound. Is there infection? Okay. Is the wound worsening or getting better? Okay. Is the wound worsening or getting better? So these are the things we have to know. Okay. Now let's look at what causes pressure injury. When pressure injuries occurs when prolonged pressure or pressure combined with shear damages the skin and underlying tissue. So look at this structure. This is somebody's sacrum, okay, or buttocks, okay, sacral bones or pelvic bones, okay. This bone is here. Already, this bone is putting pressure on the skin. Then this person too is sitting on a rough surface. First of all, it is creating what pressure, okay, friction here between the skin and what the cloth or the bed. Then there are some patients too, they slide when you boost them up, when you bring them up to the top of the bed, then they will slide down, bring them up. They are also putting some kind of pressure on the skin. That type of pressure is called shear. Okay, shear. Okay, yeah. So they have internal pressure and external pressure. All of them is crashing or squeezing and causing a lot of pressure on this area. Okay, so what now happens? You can see there are arteries here and there are veins here. If these arteries gets blocked, the cells here will not get hot blood supply, and they will begin to assume a certain type of presentation. Okay, so you looking at the wound can tell that yes, this is an arterial hot wound. Okay, then the veins too are supposed to take blood back to the heart, but when they got here, they are blocked. Okay, yes. So the veins too what present themselves in a certain way, which will also tell you what that yes, there is pressure over here. So we have pressure, the shearing, and the friction on the surface of the bed. Okay, all these ones comes together to what? Yes. So example with the pressure, sacrum pressed against the mattress for prolonged periods. The key word here is prolonged. Okay, I can't just you can't just sit on the bed today. Yes, if you sit as we are listening to me, you are as there is some pressure on your sacrum, or whether you are lying down, whether you are whatever you are doing, even if you are standing. Okay, there is pressure on the body part that is getting in contact with whichever position you are assuming now. Yeah, but stay there. Can you stay there for so many days? Blood supply and venous drainage there will be affected, which can cause issues. Okay. Yeah, friction. So I've talked about friction, the two surfaces rubbing against each other. Then shear. The skin remains relatively fixed while deeper tissues slide. So somebody will slide down the bed, remove the person back, then they slide. So what are you going to do to stop this shear as a nurse? There are some beds. So assuming the patient is like this, okay, because this place is sloping, when you move them up, then they slide down. When you move them up, then they slide down. Okay. So there are some beds. What do? You break the leg like this part. You know, some beds have what? That that remote stuff. So now, when the patient is sitting down like this, the leg will become the knee. You break the knees. How this one can never move down to cause shear at the back and the buttocks. Okay. If your bed too is not having this type, okay, but there are some beds that you can do the reverse Trendelenburg. The reverse, sorry, the Trendelenburg position, head down. The Trendelenburg, to do the Trendelenburg, tilt or change the bed position to the Trendelenburg position like this. Let their legs come up. Then when you position the bed like this, then you elevate the head of the bed like this. So the patient will assume this position. So they will not slide down to what to cause shears. So these are all the this mostly happens in what patients in high Fowler's position, okay, where they slide down the bed or the shear. Okay. Now, who is at risk? When we are talking about skin injuries, who is at risk? We have patients who cannot move, patients who feel pressure, patients who cannot communicate discomfort, stroke patients. Some of them cannot talk. Okay, a patient who is deaf, a patient who is unconscious. Okay, yes. So all these ones that the people, patients who are having neurological deficits that they can't even sense pain or discomfort. Then patients who cannot maintain nutrition. Yes, you can maintain nutrition. You don't take a lot of proteins. We eat proteins to help. Protein helps us to repair and replace the tissues. Tissues. Okay. Yes. You don't take a lot of proteins. Yes. Already, you don't also take carbohydrate. Carbohydrate helps us to what? To build the body. So once we are building the body, if any tissue gets spoiled along the line, proteins will come and replace it. Okay. Yes, they will replace it. So you are not getting all this correct nutrition. It means that you are going to waste tissues. You are not taking a lot of protein. You are going to waste tissues. Okay. And the body does not have protein stores. So if you don't eat proteins, the body does not have anything. Body cannot go and borrow carbohydrate and convert to protein. No. Body does not have protein stores. So you have to eat proteins before the body gets proteins. That is it. And it uses protein for the enzyme, the hormones, everything, nerves functioning, and all those ones. Okay, yes. So if you don't take protein, you are going to waste. That is why a lot of people do exercises. They go to the gym, they are doing weight loss exercises. They don't take protein, so you are reducing all right, but you don't look nice because you need to take protein to stay refreshed, okay, and nice outside, okay. Yes. So patients who cannot remain dry, they are always wet, they sweat a lot, secretions, yes. So if that body part is always wet and there is also friction and shear, then imagine there's going to be what? Pressure injury. Okay. So all these guys, people with decreased consciousness, people who are having incontinence to bowel and urine, okay, poor nutrition, dehydrated guys, advanced age, okay, impaired circulation guys like the musculoskeletal surgeries, okay, diabetes, edema, medical devices, and all those one people who undergo prolonged surgery. Okay, they are all at risk of what developing what pressure injuries. So for you and I to know the pressure injury, we need to use a certain skill we call what the Braden scale. and Braden scale 18 and below is a critical result that you need to report to wound care. You need to report to wound care. So who is going to do this assessment is the nurse. A newly patient has been what? Admitted, or a patient who is already on the ward. But while doing personal care, the healthcare assistants or the CNAs saw a wound or skin break. They have to report to the nurse, and the nurse will come and do a braiding scale. Okay, so the braiding scale will assess you on what? The sensation. Do you have senses at that area? So this is your bong bong. Okay, yes, we scale, and this is the place that we've observed what? The wound. Is there sensation there? Okay, you feel, you touch, you can ask the patient. Sometimes you can apply pressure there. Can they feel that you are applying pressure? If you pinch them, can they feel you are pinching them? So all these ones are there. Okay, sensation, sensory perception in that area. Then the next two will assess how moist is this area, because moisture, we learn that moisture also affect what? It puts someone at risk, at higher risk for pressure injuries. Okay. Then this area, how the activity, the functioning of this area is very important. Sometimes activity and mobility. How often are you moving this area off the bed? Are the healthcare assistants turning the patient every 2 hourly? A patient who is unconscious. Okay, so the activity, those people who have done musculoskeletal surgeries, okay, activity, how do we call it? Neurovascular assessment. Okay, yes, activity. Are you able to flex the legs? Okay, wiggle your toes and all those ones. Okay, then nutrition. What is the nutritional status of this patient? Do they have appetite? Do they eat? Do, have they been rejecting food? So you do your scale, your assessment, then you mark, you score them. So when you score and you add all these totals and it's below 18, this is a critical result that this patient needs to be assessed by the wound specialist. In US, it is the wound care nurse that will come and do a final assessment and draw a plan how we should address this wound, which type of dressings should we use for this wound, okay, which type of creams and lotions, which should we use on this wound, okay, how often we should dress the wound within the day, within the week, within, yes, so all these ones that we should do. Then is there any friction and shear? Okay. So NCLEX wants to ask you. NCLEX may not always be asked. Okay. You may not always be asked for the exact score. NCLEX will never do that. If I ask you what is their score in science score 20, that is safety question. No. NCLEX will describe a patient for you, and put in that patient is immobile, patient is incontinent, patient is malnourished, or patient is confused. All these are risk factors. So they will combine for you, and expect you to recognize that this is a high risk or high pressure injury risk. Yes. Okay, so NCLEX will combine the risks for you, because safety is always the denominator and your action is the numerator. Okay, very important. Now, the common areas that we mostly get pressure, which I'm not going to talk about because everybody knows on this page. Okay, we have the supine. When patient is lying supine, these are the areas that what they have high risk or pressure points. Okay, when patient is lying on the side, starting from the ear, the shoulder, the ribs, the greater trochanter, okay, the knees and the ankles. When you are lying face down, prone position, the face of the patient, the shoulders of the patient, especially if you are going to do surgery of the back, laminectomy, all these spine injuries, those surgeries are going to take long. Sometimes 8 hours, 9 hours, 10 hours. Patient is going to be on the face down for all these hours. Okay, you have to pad. You have to get a pad, a gauze. Okay, pad the face. Okay, pad the pressure areas. So the shoulders, the face, the breasts, if it's a woman, or a chest, if it's a man, the genital area, the knees and the toes, all these places needs to be padded. Okay, good. Now let's talk about blanchable and non-blanchable erythema. You have seen redness. You are turning a patient, you are doing personal care, and you saw the skin is intact with all the layers intact. No break. But you have seen a small redness here on what? The epidermis. Redness. Okay. Redness. You ask yourself that, is this blanchable or non-blanchable? Okay. If it is blanchable, blanching means blood arterial supply. Blood is still going. It's a technical term. On the streets, on the layman's language, we will say that what, is this part of the body still getting blood supply? How will you know? Take your finger, one. Let's do this exercise. Press on your nail bed, one of your fingers, the nail bed. Press and hold it for long. Let's say 1, 2, 3, 4, 5. Have you seen that when you press on it, the nail bed turns from pink, okay, or reddish to what? White. Yes, that means that you have stopped arterial supply to your nail bed. Yes. Now leave your finger. You see that quickly the blood will flash back. Okay. Yes, to supply that area. Good. Do the same thing for this area. Use your hand to press on it. Then you leave. When you press on it, it will turn white. Okay, it will change color. Now release your hand. If you release your hand and black, that place changes from white to what? Red again. Then it means what? Blood supply is going there. And in medicine, we call it what? This place is blanching, is blanched or blanchable. Okay. So press the red area. If it becomes pale or white temporarily, then returns red when you release your hand, then it means blood is still moving through the tissues there. So you close your mind. The only thing you have to do is to get a permanent marker and circle around this red area so that next time you come, you know whether the redness has grown past these borders. Then you know that, okay, the skin is a mirror of whatever is happening inside. So if you see a pimple on somebody's face, it can be a cancer growing in the body. If you see a pimple on somebody's face, it can be that there are a lot of sebaceous or sebum, sebaceous fluid, or a lot of fat under the skin. So it is releasing some. Okay. If you see that the skin is warm, it can be that what? The inside the body is very hot. Okay. If you see somebody sweating, that should tell you that hot. There are a lot of fluid loss coming out, insensible water loss. Okay, coming out. Yes. So all these things, the skin is a mirror of whatever is going on. Of whatever is going on. Okay, good. So let's look at non-blanchable. The same skin with redness here, no break. Everything, the epidermis is intact. Now we pressed here. Okay, the color does not fade. The redness, it does not become white. It is still red. Even if you press down, it is still red. That should tell you that what blood has something is going there. Blood, it is pooling here, okay, under the skin, and the blood supply is blocked. Okay, so this place is not getting enough blood supply, or they are not getting blood supply at all. Okay, what now happens if you leave this area for long, because they are not getting blood supply, the cells here begin to die. Okay, yes. So this is what a possible what stage one injury, a possible stage one injury. Let's see if I'll. So this is stage one. Look at the redness. Okay, so you press on it. The skin is intact. The epidermis, the dermis, all these layers are intact. So this is what you should also what take note of. So stage one pressure, let's now stage them. Stage one pressure injury. The skin is intact with non-blanchable erythema. Okay, yes, or discoloration. Non-blanchable. Before you stage, if you press on the redness and it is blanchable, that is not stage one. But if you press on the redness and it is non-blanchable, the redness does not fade when you press on it, then it means that the person has an injury. And we call this what? Stage one injury. The skin is intact, it is not cut open. The skin is not broken. Okay. In darker tones like me, the change may not appear bright red. So also assess the temperature around. How firm is that area? It can be a cancerous cell. Okay. How painful when you are touching me. So if you come and see me, you are assessing me, maybe you are bathing me or putting cream on my body. Okay. And because I'm dark, I'm not fair like Ayariga or Miss Everest. Okay. And and you touch my skin. How can you see redness on my skin? You won't see it. But you look at what this area sometimes is dark, more darker than the skin. Then you assess the temperature of the area, the firmness, the pain, the tissue consistency. Okay, yes, is there break in the consistency or the consistency is intact? The skin tegel, all this one you should note. Okay, so stage one injury, the skin is intact and also it is non-blanchable. Take note. You cannot do a wound assessment without writing the stage of the wound as a nurse. Okay, and the measurement of the wound with your tape measure. Stage two. This is the picture of stage two. Look at stage two. Okay, so let's go and learn about it. Stage two. With stage two, before they used to call it partial thickness. Okay, partial thickness skin loss with exposed dermis. Yes. So this is the layers. This is the so the top layer here is very tiny. It's called what? The epidermis. Epi. Then below it is the dermis. Okay. Yes. Then it goes like that. So as we move along, I'll be adding up so that you see. You went and saw that hot. This part, I don't want to. This part is broken like this. When this blood gets broken and it wears off or it tears away, skin tear, you see the epidermis because the one lying under it, you will see the epidermis. Okay, yes. So the top layer is weared off. You are seeing the epidermis. Okay, Good. You are not going to see muscles here. Remember, if I do this thing, skin grafting, and I take the top layer off, okay, you are seeing the epidermis. There, the epidermis. You are seeing the epidermis. So you will not see fat, the subcutaneous tissue. Okay, you will not see the muscles, the tendons, and the bones down there. So under the epidermis is a very big fat layer. It helps to keep body temperature. So this is the fat. Then under the fat, we have what? The muscles. Okay, so the muscle will come here. The muscles are attached to the bones like this. Let me draw bone well. The muscles are attached to the bone like this here. What connects these two guys is a certain structure we call what? The tendon. The tendon. So the tendon connects them together. Okay. If I move my bone, the muscles too will stretch. It will move along. If I flex it or extend it, the muscles will move along. Why? Because of the power of the tendon. If the tendon tears, can the bone and the muscle move together? No. We will get to that. Somebody is giving you a lot of magnesium sulfate. Okay. That max sulfate is going to affect the muscles and affect the tendon. But how will I know that the muscles are in big trouble? If I take any metal and I hit on the joint, the muscle is, the tendon is highly sensitive. That when I hit on it, you reflect. Imagine you hit your knee against something. You see how the electrical shock moves you. Yes, that's the power of the tendon. Okay, so I'm hitting you, the tendon, and it is not reflecting, it is not reacting. That means that what? The deep tendon reflexes is reducing. Because I'm giving a lot of what? Max of it. Okay, now what do I have to do? I have to stop the max of it, because if you don't stop it, the muscles too will be affected, and you get muscle weakness, difficulty breathing, all these ones. Okay, wide QRS complex. That is just by the way. So the epidermis on stage 2, the epidermis is gone. Let me remove the epidermis. It's gone. So I am seeing what? The dermis. I'm seeing the dermis, but I will not see the fat and the muscle and the tendon and the bone under it. I'm only seeing this. Okay, so take note. Good. There is a trap here. Do not classify every shallow red wound as stage 2. Okay, some people have incontinence dermatitis or skin tear or burns or adhesive injury. They are not, the fact that you have seen these ones does not mean it automatically is a pressure injury. Ask what caused the injury. Okay, yes, the fact that you have seen a wound does not mean that you should call it a pressure injury. Okay, you ask what caused it. The mechanism describes what we call what. So I saw a wound because this patient has been on this bed for long. Okay, it's a prolonged exposure of that part of the body to a pressure. That is what we call what? A pressure injury. Okay, somebody is cutting onion at the kitchen, then knife cut the person. Is that a pressure injury? No, the dermis, the dermis or whatever structures are exposed. You can see it. but you can't call that one a pressure injury because that is not a prolonged pressure that has caused that injury. Okay, that is all you should know. Now let's go and look at stage 3. Stage 3, we call it full thickness. Before, nowadays they've changed all these physiologies, okay, and namings, because anatomy A is A, but physiology A can never be A. The A of yesterday will become B today, and the B of today will become C tomorrow. That is physiology. So research is always ongoing. If you don't do, some people will do and change the notebooks. Okay. So the stage 3, in stage 3, remember we were having what? Epidermis, epidermis, and what? A subcutaneous tissue or fat, adipose tissue. Then we have what? The muscles, the tendons, okay, and the bones, okay, and the bones. Good. So with stage 3, here cannot remove until here and here removes. So you can't have your adipose tissue removing and the epidermis and the dermis are intact. So you just have to remove the epidermis, remove the dermis, okay? And what is left? The adipose tissue is there. So with stage 3, if you get a wound and you are seeing a lot of fat on the wound, that is what a stage 3 injury. Okay, yes. So fat may show on stage 3, adipose fat may show on stage 3. Over here, the fact that you are seeing fat does not mean you can see what? The muscles, you can see the tendons or the bones. The wound must still go down, like we are doing galamsey, we are digging down. Okay, yes, before you can see all these. Yeah. So stage 1, stage 1, the epidermis, okay, with a redness and non-blanchable is stage 1. Stage 2, if you know the layers of the skin, wound assessment is something on your fingertips. Okay. Stage 2, the dermis will be shown. Okay. Yes. In stage 3, the dermis is gone and the epidermis is gone. So it's left with what? The fat. You can see the fat. Sometimes you see cuts in the fat or the fats are intact. That is what? Stage 3. Good. So you see granulation tissues, undermining, tannin, epiboles. I mean, so many descriptions, but you will never see exposed fascia, muscle, tendon, cartilage, or bones. So these are the things you should know. Okay. Let's go to stage 4. That is a full thickness. Forget about nowadays. Don't go and write this in your nurse's notes. Stage it. That's it. Then you are done. Nowadays you don't do partial, whatever. No, stage it and you are gone. Okay. Yes. So stage 3, there is full thickness skin and tissue loss with exposed or directly palpable deep scratches. So over here, what is the skin? The skin has an epidermis. It has what? The dermis. It has the fat or subcutaneous tissue, the fat. When I take everything away, I have taken the totality of the skin. Okay, the totality, how do you spell it? Or the fullness of the skin. That is English. That's why we say the thickness. How will I measure thickness? From the top here to here, depth. Okay, so all the full skin is taken away. The epidermis, the the dermis, and the subcutaneous tissue, I've taken all these ones away. The full thickness is gone. Now what is left is now left with what? The deep structures, the muscles, the fascia, the tendons, and the bones are here. Okay, yes. So you can see all this undermining and tangling, and oh, let's see if you can get some pictures here to show. Okay, I should have added the pictures to it. So look at stage one, non-blanchable. Stage two, we have entered into what? The dermis. Okay, stage three, it has gone down toward the subcutaneous tissue. Okay, yes. And let's go to stage four. Okay, so stage four, you begin to see what? The deep stretches. Okay, the deep stretches. Okay, we have another type of wound staging. We call it what? Unstageable. If I see a wound in the skin like this, and I come and here is covered with a canopy, a top layer that is black. Eh? That is black, and it's the arteries that cause that. That is an arterial wound. It is the arteries that cause that. This is not the vein. Okay, the arteries, mostly dark wounds, are caused by what? Arteries. Okay, so when you block the arterial supply to this area, the tissues here will die and they become dark and hard. So if I want to treat this, I have to remove the black thing, the eschar, whatever, black thing. I need to remove it. Until I remove it, if this place is covered with black tissue, is the dermis black? No. Is the adipose tissue black? No. Okay. So how will I be able to stage or classify this wound? I will classify it as what? Unstageable. Yes. Even if it is a deep wound affecting the muscles, the tendons, and if you see any black or dark canopy covering the wound, it is called what? Non-stageable. Yes. So this is a full thickness tissue loss is present, but the true depth cannot be determined because the wound bed, the bed of the wound, the inside, not the foundation of the wound. Okay, this is the skin, this is the wound. Okay, yes, the bed, this the inside here is the bed. Is obscured, is blocked by either a slough or a scar. A slough. The adipose tissue is not a slough. The muscles are not sloughs. If I cut your muscle now, I'm not going to find sloughs there. It's not part of the muscles. So any structure, any presentation that is not part of the original anatomy of that human being is called non-stageable. Okay. Yes. So a wound covered with black eschar is not automatically stage 4. Okay. Unstageable, according to this organization, specifically recognize unstageable wounds when the wound is obscured, but depth cannot be determined. Okay, that is it. So if you look at the pictures, you see what this black eschar here. Yes. Underneath the black eschar, you see how the wound has gone deep. But the surface that will allow you to see the bed, the down part of the wound, is what you can't see. It has covered all the wound depth. So you can't see. So if you want to see, you have to remove this. Should the RN do? No. It is the job of what? The wound care nurse. But the patient belongs to the RN. Okay. That is why the RN must know what is going on. Good. Now, deep tissue pressure injury. Deep tissue. So we have what? Deep tissue pressure injury may appear as persistent deep redness, maroon, purple discoloration, blood-filled blisters, okay, and dark wound bed under intact or disrupted what skin. Good. So sometimes NCLEX can give you what all these guys pressure history. Think about what deep. Think about deep pressure injuries. Okay, deep pressure injuries. Okay, deep wound. So the master table is here if you want to know it. The master table is here. I have gotten a wound. My skin is intact. Okay, but I have blisters on it. A patient has come with what? A burns. Okay, what is causing the fluid to move from down here? Do you know where the blood vessels are? They are very deep, okay, especially the arteries. So for me to move a plasma from the blood vessel and for you to see the plasma on the skin as a deep, as a blister, then it means that deep down here, I have a big injury that you cannot see. So it is giving you a reflection of whatever is going. You see all this maroon and all those stuffs. So these are classified as deep tissue injuries. Okay. Somebody's skin is purple. Okay. What is causing blood to move here to cause all these bruises? It means that deep down there is an injury that has occurred, and the skin is giving me a reflection. So ask yourself, does your skin change color if you have trouble inside? Eh? Does your skin change color if you have trouble inside? Good. Pressure injuries do not reverse the stage. So stage 4, injury begins healing and bone is no longer visible. Okay. So do not say now it is stage 3. No. Instead, healing stage 4 pressure injury. Why do we say that? Example, let's say this is the layers, okay? The epi, the dermis, okay? And so the dermis and the adipose tissue. So there was a break here. Now the adipose tissue has healed, or the dermis has healed. You are seeing good granulation tissue. It has healed. Now it has gotten to, it heals from down to up. The fact that here has healed, never say that this is what stage 3. The wound has healed to stage 3. No, you say that this is a healed stage 2, stage 1, stage this pressure injury. Yes, that is what. Because the stage reflects the deepest known tissue damage. The deepest. If you know the layers, that is it. Okay, we have moisture associated damages. Urine, stool, sweat, wound drainages can affect that. So those of you who are managing incontinence patients, is it urine incontinence or bowel incontinence, plus irritants, all these creams, the skin shearing and pressures will cause all these ones. Okay. Now, pressure injury prevention. How do we prevent it? According to this organization, regular and constant skin assessments. Train your train your nurses. Okay, if you are the ward in charge, train your nurses to be able to what? Assess wound, assess the skin. Pressure redistribution. How do we do pressure redistribution? A patient is unconscious, lying on supine today. Okay, all the pressure from the bed is what going to one direction of the body. The other part of the body are not getting the pressure some. So what do we have to do? 2 hours time. Let's turn the patient from supine to, let's say, left lateral. So in that case, we have relieved pressure on the back, the supine areas, and we are putting pressure to what? The left. 2 hours time, let's turn the patient to right. Another hour's time, let us elevate the bed. So we are doing pressure changing positioning. Okay, we call it pressure redistribution. Then offloading the legs, the heel. This heel should not touch because this heel has very little tissues. Okay, because of the bone here. So if you are managing unconscious patient, if you are managing a patient who cannot move, they are in bed, bedridden, this heel should not get contact with the bed. That you should place a pillow here, here, to elevate the heel from the bed like this. If this is the bed, a pillow here. Don't put the pillow here. Nurses make mistake always. You see nurses putting the pillow. Oh God. Okay. Yes, this is the leg. You see nurses putting another pillow here. What are you doing? You are not solving any problem. You are creating another problem at the heel, another pressure problem at the heel from the pillow. The pillow should rather be here. The pillow should be here. And this one will be hanging. This side of the heel will be hanging. Okay, yes. So moisture management, adequate nutrition and hydration. Okay, adequate support surfaces. Okay, make sure you proper nutrition, reassessment, dry skin, and pressure off the bed. Good. Repositioning should be done every 2 hours. NCLEX recommend. Okay, reposition. You can reposition patient thinking about what, or before you reposition a patient, think about the risk. If somebody has a spinal injury, will you say that it's 2 hours? I need to reposition this patient, so let me put the patient in a Fowler's position. You're going to spoil the spine. Okay. Yes, so you think about the risks. Think about mobility. Is it helpful? Okay. Think about the skin tolerance. If you put the patient in this position, will the skin tolerate it? Okay. Look at the surface you are going to reposition, the bed, the creases and the cramps, okay, of the bed. The bed sheet, is it moist? Let you there are nurses, when they see that their patient's bed sheet is wet, they won't change it. Moisture creates a lot of pressure on the skin. Okay, so that's why you need to change the bed sheet. Then your draw sheet, your draw sheet, yeah, those rectangular sheet, okay, to help you to move the patient, boost up and down. Then clinical hot conditioning, yes, avoid prolonged pressure. We have talked about the heel offloading. Okay, so proper offloading means remove sustained pressure from the heel. Okay, yes. So often this involves supporting the calf, onantu, the calf or the lower leg, so that the heel can what, feel free from the mattress. Okay, yes. So this is what you should know. Then you also support surfaces. High risk patients may require what? Pressure redistribution, special overlay mattresses like what? Pressure mattress, air mattress. Okay. In the wheelchair too. Some patients, we carry them, put them in a wheelchair, we bring them to the lounge. Okay. They are sitting at the lounge the whole day. Pressure. Okay, so mattresses, that foam mattress, that is pressure. Okay, prevention. So all these cushions, wheelchair cushions, when you come to abroad, you see them. Okay. Heel protection and offloading devices to help. Okay. A specialty mattress does not replace repositioning. You still have to reposition. You still have to apply your creams to pressure areas. The patient must still eat, and the patient must what? The nurse must continue with the reassessment. Okay. We have donut cushions. Donut cushions. What is the donut? Donut is like this, and they have a certain hole in it. So if this patient sit here, the sacrum will be hot. Or we can put somebody's heel, the legs will be here and the heel will be here. Okay. It helps with what? Pressure distribution. Some people also have, you see that cushions or pillows that pregnant women use when they are sleeping on their side and all these ones. So all those ones are different cushions. When we say pillow, we have pillow for patients who sleep supine. Okay, and patients who sleep on their side sleepers. Yes. So all these ones you should know. Now, nutrition. A patient must eat the calories, the proteins, the fluid, and the minerals. You see, they did not mention what fat here. Okay. Yes. A little bit of carbohydrate, calories. Okay. A little bit of protein, fluid, and what? Vitamins or minerals. Adequate nutrition is very important. Okay. Yes. So if there is no building material, then think about what? There's going to be what? A poor rebuilding or a poor building. Yes. So protein is very important with these patients. Are you giving them yogurt? Okay. Are you giving them meat? Those who are working in care homes. Okay. How much proteins are you giving to your patients? You are loading them with carbohydrates. The carbohydrate will change to fat. Because the cellular repairs, the collagen fibers, okay, their elasticities and their integrity. Then the immune, the hormones, and the enzymes need what? Proteins to survive. Good. The healing phases of wound. So before a wound will heal, understand this sequence. There is hemostasis. Let's say this is the skin. The skin has cut. One. You are bleeding. You are bleeding. You are bleeding. You are bleeding. If I want this skin that is torn to heal, what do I have to do? I have to stop the bleeding first. That's the first action. We call that one hemostasis, stopping the bleeding. Yes, so we know the clotting cascade. The platelets will aggregate and the fibrin will form, ovariate, okay, and they will heal, the wound ends will heal, come together. New cells, by the help of protein, will replace the lost cells, okay. Yes, and after everything, these ones, this platelet, the clot here will be absorbed by the body. Okay. So in this process, after that, after you stop, the white blood cells enter. When you got the injury, you are sitting on the bed. Is the bed sterile? No. There might be an organism here that has entered the body. So whilst we are stopping the bleeding, white blood cells are also following the blood there to go and fight any microorganism that will try to enter the body through that channel. Okay. In the action of the fight, the body will produce what? Inflammatory responses. Okay. Yes. So we will see the five cardinal signs of inflammation there: redness, warmth, swelling, tenderness. There can be pain. These are all telling you that what inflammation is ongoing. Okay. If you are able to fight all the infections, then now it is time to make sure that the skin becomes intact again and not what? Broken. Okay. So we call it what? Proliferation. There are cells here and there are cells here. Okay. Is the proteins or are the proteins going to borrow cells from the leg and bring it here? No. What they do is that cell here, they will just multiply it. Okay. Multiply it and make sure that how can these cells connect together? We need collagen fibers. Collagen, like super glue to what? Help it to attach to each other. Okay, yes. Then we have what? The epithelial cells will come in. We call it epithelialization. Yes. Then what? Granulation. The granulation is what you see, and the skin, there's that surface is very pink. Okay, in nature. Yeah. So they do all these physiologies to make sure that what wound is healing. But sometimes people get problems here. Okay. Sometimes while we are getting new cells, we start getting abnormal cells. And out of that, people get cancer. People get all these issues. Okay. Old new cells are coming to replace old cells. Cellular mutation. In the process of creating new cells, there was a disorder. Now the cells we are producing abnormal cells rather. Okay, you start getting all these cancer. So somebody got a wound, just a normal wound, but that wound has turned into cancerous wound. Okay, somebody got a normal pimple, but that pimple has become what? A cancerous structure. It is a problem of the proliferation. Sometimes there is overproduction of these structures. Okay, yes, and they need blood to grow. Okay, and so they'll get the blood. Now the maturation, that is where the scarring comes in, the scar tissues. So this the once we have been able to what connect this side and this side with the help of new cells. Okay, we have to make sure that this place is intact. Do we need a fibrin? No, we don't need a fibrin. Okay, we need more chemicals that will help this place to become more fixed and strong so that there's not going to be any wound dehiscence or cause any eviscerations. So we need to mature that cells that were produced here. Okay, yes, in the stage of maturity, some of the cells will become scarred. And when the cells become scarred, it means no hair is growing through. Underlying structures that will have to grow from inside to out will not happen again. So take note of that. Will never happen again. So take note of that. Okay. So all these ones will help. So the scar tissue reorganizes and strengthens over time. Okay. Good. Granulation, slough, and eschar. We know granulation tissue is a healthy tissue, pink or red, nicely. Slough is yellow or tan, sometimes white. Eschar is always brown or black. Okay, so take note. Yes, take note. So you cannot stage eschar or hot sloughs. Wound drainages. A wound is draining. Yes, some fluid is coming out of wound. What is the color of that fluid? It will tell you where that fluid is coming from. Okay, the color of the fluid will tell you where that fluid is coming from. So if the color is pale yellow or colorless, we call it what? Serous. Serous. Yes, the serum. Aha. So you know the serum, when we take the plasma, the serum, the plasma, the serum, the water part of blood, the water part of blood. And remember, the plasma contains what? The clotting factors. The plasma contains what? The red blood cells. The plasma contains what? The white blood cells. Okay. The plasma contains what? The platelets. So you are seeing the serum. Okay. You are seeing a plasma with a lot of red blood cells in it. What will be the color of that plasma? It's going to be red. So you see what? Blood in it. Okay. Yes, blood is coming out of a wound. That is what? A serum. Okay. That is what? But that plasma that is coming, you are seeing, if this is the plasma, you are seeing a lot of red blood cells, plenty in it. What is now happening? You are wasting red blood cells. What is the function of red blood cells? They carry what? Oxygen and hemoglobin. So if you are wasting a lot of red blood cells, it means what? Your red blood cell count is going to reduce. Good. So how will you see the color of that fluid? It's going to be bloody, red. As the wound healing is ongoing, and as the clotting cascade is ongoing, and as the blood cells are repairing themselves so that the blood cells will not be lost, the number of red blood cells will be reducing, but this plasma, the volume will still be the same. So you realize that a time is coming if we see a certain fluid coming out of the water, the womb, but we don't have enough what? Red blood cells compared to the first. Just a few red blood cells plus water, H2O. Okay, water, H2O, plus water, H2O. They are mixed. So this one will be deep red. But because this one, the red blood cells are not plenty, they will tend to what? A mixture of serum and what? And blood. Here, it was plenty blood, more than the plasma. Now, over here, as the wound healing is ongoing, we will see what? Little red blood cells, because the body is trying to capture the red blood cells to themselves, and what? Let IV fluid can be lost. You can drink, but red blood cell, you need to transfuse the patient. Okay, yeah. So you get what we call a mixture of red blood cells and the plasma. We call it serosanguinous. Serosanguinous. Okay, good. Now, purulent infections will come in pass. Pass. When you see pass, it means that infection is ongoing here. Okay, yes. So pass, yellow pass, green pass, tan. Sometimes the smell of the pass is also important. Foul smells. Okay, I should tell you that what infection is ongoing. Okay, good. A small amount of serosanguinous drainage shortly after surgery may be what? Expected. Pregnant woman, you went to do CS. Okay, yes, serosanguinous. It's expected. It's very expected. But it has taken days, it is affecting your vital signs. That is where we come in. Sudden increase in bright red drainage. Bright red drainage. Where is it coming from? It is coming from what? The arteries. Because in the cardiovascular system, we only find bright red in arteries and what? Dark red in veins. So a woman has come with what? Vagina tear, with bright red blood coming out. Arteries are losing blood. Yes, it's going to affect your red blood cell. Okay. If there is what? Hemorrhage accompanied by hemodynamics, okay, or tachycardia, hypotension, pallor, weakness, this question now moves from wound to what? Circulation or cardiovascular emergency. Because if you don't treat this, you're going to get what? Hypovolemic shock. Okay, hypo shock. Yes. So these are the things you should know. Okay, wound infection, we have talked about it. How will you know that the wound is infected? There's going to be pus, there's going to be swelling, fouls, there's going to be fever, localized, and if you don't do anything about it, it will enter into the bloodstream and cause systemic fever. Okay, worsening wound appearance, it changes. Okay, becomes greenish, scar, all these ones, and pain. So I've told you that what infection, if you mention infection of a wound, think about what the five cardinal signs of inflammation. You are done. Okay, because itis, infection is itis. It will cause inflammation, itis. So if you know the five cardinal signs of inflammation, okay, then you should know what wound, you should know infection. Okay, you should know infection. So these are the things you should know. Okay, now wound, they say wound healing by primary, secondary, and third intention. What does it mean? When we say a wound has healed, or a wound will heal by what? Primary intention. It means the wound edges are brought together. Okay. They are brought together. Example, a clean surgical incision. Healing is generally faster with less scar. Okay. Yes. Healing, so the doctor did an operation, he has sutured the skin back. Okay, yes, sutured. So we have a big wound like this. Then we go and do what? Wound debridement. Taking off all the eschar and all this tan and everything. Then we suture this wound back like this with clippers. This wound is going to heal by what? First intention or primary intention. Secondary intention, we can do the wound debridement, or we can dress the wound like this, or we can do the surgery and leave the skin to what? Heal by themselves. So they will heal, they will proliferate and form their own cells. Okay. And the bigger the wound size, the bigger the scarring. Okay. Because we need, after the proliferation, that will bring the skin together. We need what? The maturation stage. And the maturation is what will bring the scarring, because that part must be tough. So this is going to cause a lot of big scar here. Yes. So common, larger tissues, pressure injuries, all these ones. Okay. Tertiary intention. The wound is intentionally left open initially and later closed after contamination or infection decreases. Okay, yes. So we can do a wound debridement for you. Then we can say, okay, let us now keep dressing the wound, keep dressing the wound. Make sure that, so once we see granulation tissues forming, then we know that, oh, okay, if we join the edges of the wound with a suture, okay, the wound will heal. That is it. So don't let it confuse you. Now, in the process of joining the wound edges together, remember pressure, internal organs, internal pressure, okay, or pressure from outside. Okay, somebody is coughing back from theater, is coughing, putting a lot of pressure on the abdomen. Meanwhile, there is an abdominal wound. The nurse forgot to teach and educate this person on what? Coughing and with abdominal wound and all these stuffs. Okay, so that wound is going to gape. On the layman's language, we say gaping. It's going to gape. Okay, if it gapes, if the wound opens and nothing, no internal structure, eh, no internal structure get out, that is what we call the dehiscence. Okay, but the internal structure, how do we call it? We call them viscera. The internal, we call them viscera. Okay, the visceral structures, internal structures like your intestine, your gallbladder, those internal you can't see. If you look at me, can you see my internal organs? No, you can't see. So we call it what? The visceral structures. But if the visceral structures get a hole and they exit out, we call it what? Evisceration. Evisceration. That is it. Okay. Evisceration. So we say the wound has eviscerated, meaning the wound edges opened and the internal structures has protruded through the wound. NCLEX has a big question for wound evisceration. Somebody's wound open and you have seen a small intestine coming out of the wound. So let me show you pictures, okay, so that you understand it well. So this is wound gaping, dehiscence. You see the internal structures are intact, just that the sutures have torn. Okay, this is dehiscence. Look at the evisceration, protrusion of what? Bowel or intestines or any other organ. Are you supposed to push this structure back in with your hand? What are you supposed to do? What is the nurse supposed to do when you see this? Is the nurse going to suture this back? No, it is not your job. Okay, so all these ones are there. So don't let them confuse you. It is English that they've joined. A visceral organ has exited the body. So we call it what? Wound evisceration. Okay, wound evisceration. Good. So what are the risk factors? Somebody infection at the wound side can cause what? The tissues and the cells to become weak, and their elasticity or the collagen strength will become weak. Sometimes the collagen this thing will even get torn. Okay, yes, and the wound will gape. Somebody is obese. If somebody is obese, the outside structure is the same thing you see inside. So there's a lot of pressure from the inside to the out. So poor nutrition, you don't eat well, you're not getting more protein. Coughing can cause dehiscence. Vomiting, pressure causes abdominal pressure. Then increased abdominal pressure itself. Okay. Then poor healing. Okay. So a sudden increase in serosanguinous drainage will make the wound bed wet. The structures will become soft. The tissues or the sutures will get torn. It can even cause infection at the site. That is why they say that keep your wound dry and clean. Keep your wound dry and clean. Keep your wound dry and clean. Okay, good. So you know evisceration now. What should the nurse do when you see internal structures coming out? You are going to stay with the patient. You are going to reduce tension in the hot incision. Okay. Cover the exposed tissue with what? A sterile saline moisture dressing. So take a gauze, add sterile saline to it. Okay. The saline bag, the bags, so sodium chloride. Okay, the bag is in the one inside is sterile. Okay, so you cut, then you pour it on the gauze, you wet it, then you cover the structure, the internal organ with that gauze. You stay with the patient. If you have your phone with you, call the doctor or the surgical team, let them come. Okay. Yes. You are not going to give any patient anything to eat by mouth to cause any more internal pressure. Okay. Then you prepare the patient for what? Surgery again to go and repair that structure. That is it. That is your job. So any question that comes with the evisceration, this is all you are supposed to do. You don't have to stretch yourself. Okay. Good. So never, what you are not supposed to do, never push. You see answers like this. Don't let them confuse you. Never push the organs back. Never leave exposed tissue dry. You've seen somebody's intestine, gunshot wound, intestine is out, car accident, a baby's leg is out, okay, from the pregnant woman. And don't leave it dry, cover it with a wet gauze. Allow the patient to walk. Never do that. You cause a lot of internal pressure. And don't give anything by mouth to eat or drink. Okay. If the patient wants is thirsty, we have IV fluid, give it to the patient. It'll be okay. Okay. Not even ice for them to chew. So these are the things. Now let's go and look at drains. Get into the close of skin. Let's do drains. Drains. Get into the closure of skin. Let's do drains. We have so many drains. Yes, if we do surgery for you, or if you have a big wound and we are treating the wound, and the wound, we anticipate that this wound is going to have a lot of fluid drainage. Okay. Remember, we don't want the wound to be wet, plenty. Okay. Yes, we need moisture. The cells need a little bit of moisture for cellular growth. Yes, every cell has water in it. They need water to reproduce themselves and to grow. But they don't need plenty that will come and wet the wound bed. Because remember, bacteria and microorganisms also need that wet environment. Everybody wants something that is wet and to enjoy life. So wetness is good. Good. So you need the fluid, but you don't need it plenty. So when this wound is overproducing fluid, or when we anticipate that this wound is going to overproduce more fluid, we put a drain inside the wound. Inside the wound. And we have so many types of drainage. Some of the drainage will put pressure and what? Will put pressure on the wound and suck the fluid out. Some of them too will not put much pressure. It's just there, it's hanging, draining under gravity. Okay. Some of them too does what? Open drainage. So we have the three types. We have the JP drain over here when you come, especially those who will be working on message and all this auto. If a patient has JP drain, Jackson Pratt drain, JP. Then we have the Hemovac. It uses vacuum to suck the blood out. Excess blood and excess serum and fluid, suck it out. Use a hemovacuum, blood vacuum. Okay, hemovac. Then we have the Penrose. Okay, so I'll show you. It depends on what. Anytime you are working with drainage, you assess the amount of fluid. A patient, a patient who has undergone surgery, day one, if the person is having 100 mils in the drainage fluid, day one, on day 5, do we expect to get 500 mils? No, something is wrong. As the days goes by, the amount and the consistency should reduce. The color should change from red, bright red, that is serous sanguinous, then serous, okay, that is no red blood cell, olive plasma. Then with time, the plasma to stop, okay, and it goes like that. The character of the drainage is very important, and what any sudden change with the, because you can't go, especially if somebody has a chest trauma, okay, that we have put a chest tube there to suck or to bring out the drainages. Okay, we expect that, yes, the chambers and their nature, chamber 1, chamber 2, chamber 3, you are observing it. Then suddenly you realize that one of the chambers is having more bubbling, regulars, whatever. So all these ones will cause alarm. You need to reassess the patient and the drainage system. So if you want to see pictures, I have pictures for you for the drainages. Mm. This is what JP drain. You see it a lot. Okay. So it drains into this nicely. You see it a lot, especially those who are working on message. It flows under gravity. It has less effect. It doesn't put pressure in the internal organs to suck the fluid out. It is draining under gravity. It is draining under gravity. This is the JP drain. Okay. Then we have the hemovac. So you see this create a vacuum. Okay. And it suck the blood out like this. It suck it out. Then we have the Penrose. Those who work in theater, you have seen this before. Penrose, the Penrose drain. Yes, it's very soft rubber. Okay, yeah. So yes, okay. So these are the things you should know. Okay, good. Then I have a slide on drainages. I'll just put, I did it for someone because she was going to do a presentation for all the hospital lines and tubes. I'll look for it and send it to you. Okay. Yes. I do that for people if people are going to do presentations. Yes. So if you contact me, I'll do it for you. I'll do slide for you to go and present. Then you get your award. Okay. Good. So the JP drain is uses a closed sectioning. Okay. Yeah. So this is the bulb. If the bulb remains fully expanded, suction may be lost. Okay. So that is one thing about the JP drain. Uh-huh. It's like in Ghana we have the something we call bentia. Okay. Yes. So you need to deflate the ball. Okay. So that it will suck the drain out. But if you are deflating and it's not deflating, then trouble come. Okay, like this, like this. Okay, you see the guy is deflating the ball so that it will suck the blood out. Okay, yes, you deflate it, then you remove this knob here. But if you are deflating and it is not deflating, then it means there is a trouble inside. Okay, good. So these are the things you should know. A wound drainage is in place and suddenly there is no drainage. Suppose a wound drainage produces 80 mils each shift and suddenly nothing, especially the chest tube. That's why I've said that if you are working with a patient who is having chest tube, okay, at the start of your shift, go and mark. Every nurse should get a permanent marker. So I started my shift as say this is the calibrations on the chest tubes with the numbers there. So what will you do? At the start of your shift, you started work at 7 a.m. Okay. So you write your 7 a.m. here. Then you close work at what? 7 p.m. So 7 p.m. You write it here. So when you are doing your documentation, you know that, oh, when I came to work, the drainage was here. And when I'm closing work, the drainage is here. Okay, the drainage was at 50. And when I'm closing work, the drainage is at 100. So within the 12 hours, I had what 50 mils drained. A chest tube that was done yesterday, less than 24 hours. You started work at 50 mils, 7 a.m. 7 p.m. You came, the chest tube is still at 50 mils. There is a problem. What is happening that we are not getting drainages? You need to report to the doctor. So those of you who will be working with chest tubes, always mark it. If you don't mark it, they will report you, especially those who would like to go to ICU. You can't go and joke with monitoring in ICU. Okay. Yes. Yeah, the slide I will be posting, it has chest tube. It has all the tubes and the lines. So the central lines and the chest tubes, the IV lines, the PEC lines, and everything. Okay. So every line you see in the hospital, in every tube, okay, good. So these are the things you should know. Then the drainage is sudden, somebody's drainage. Is there something here I missed? If the surgical area becomes swollen, painful, firm, do not celebrate. Okay. Yes, you think about possible drain obstruction or internal fluid collection. In with chest, you are going to get a recurrence of what? Pneumothorax, okay, or hemothorax. So there is a drain ongoing. Suddenly, the color has changed to what? Bright red. Okay, think about what? There is an active bleeding. I've told you that drainages and their color is very important. If you see red, if I cut open your body, the only red fluid I will see is what? Blood. Okay. Yes. Is it bright red? If it is bright, it is coming from the arteries. If it is dark, it is coming from the veins. Simple. So that is what you should know. So with that, we are done with what? Wound and all those stuffs. Okay. We have done with wound, we have done with skin, we have done with drainages, we have done with wound assessment. From today onwards, you know how to assess wounds. Okay. We have 1 hour to leave the line. So let's see what we can get out of it. Let's look at medical devices, basic care and comfort. Basic care. I have come to you, I can't breathe. I have come to you, I have spinal injury. I have come to you, I have fracture. I have come to you. What device will you use on me to give me comfort and peace, take me out of pain? Okay, you are not doing palliative care. Somebody cannot eat, but every human being must eat. The person is having dysphagia. When he eats, then he's choking. Can we go and do a peg tube for this person? Somebody is having what? Urinary retention. You do a bladder scan. The urine is very plenty in the bladder. Okay. Yes, it's not the fault of the kidney. The kidney is draining fluid, urine, but for some reason there is an obstruction somewhere. We did a scan and we saw a lot of fluid. Patient is complaining. What do we have to do? We pass catheter to drain it, to bring comfort. Yeah. So these are the medical devices that we have. But these devices can cause pressure injuries to the skin. Okay. To the skin, oxygen tubing can cause pressure injury to the nostrils, the anterior nerves. Okay, so you have to. We have some oil medication that people who are on oxygen, you give it to them, then they rub it here to prevent friction, because oily. When you apply oil on two surfaces, it reduces friction. Somebody is having a face mask, it will draw lines here. Okay, to draw redness here. Face masks. What type of face mask are you using? Okay, can you go and give a children's or pediatric face mask to me to wear? It will cause a lot of pressure with the strap. Okay, cervical color. What size are you using for this patient? What size are you using for this patient? Okay, splinting. And if you splint and you don't splint well, you cause what we call what? Compartment syndrome. So you cause more pressure in the internal structures of the skin. Okay, and casting too is very important. Okay, we have some and then catheters. Catheters will put pressure on the skin and also on the urethra. So urethra injury, feeding tubes. If you look at the ostomy, the opening of the feeding tube, the ostomy, yes, you have to take care of that area. Apply creams. Don't let overgranulation. A lot of people, sometimes you go to some unit and you are doing feeding, you realize that no, this guy, why should you allow, let's say, let me show you this so that you understand. This is the skin, this is the feeding tube. Remember the feeding tube, some of them have this ball, this round thing like this, like the peg tube. Under this and that, eh, they can be rubbing. They can be rubbing against each other, and the tube will be here with the wire connections that you are feeding. Okay, but remember this round thing here, and this is the skin of the patient. They'll be rubbing with each other. Do you lubricate here? Do you keep here dry and clean always? Anytime you feed a patient via the peg tube, do you clean this place and make sure that it's dry? Do you lubricate? If you don't do that, the rubbing here will cause the internal structures here to overgranulate. They will think that there's an injury here. So let us overgrow ourselves and come out and come and heal this wound. So you realize that sometimes when you lift that ball, when you lift it, you check under the ball and the skin, you see that there is a fold of skin here that is very red. They call it overgranulation. Yes, granulation tissues are good. But do you want granulation tissue on your skin for what? Okay, so that is what you know. So you should lubricate there, keep it clean, and all this one. Turning the patient does not protect the skin beneath every device. You must inspect around and under devices when safe. So this is what you do. Mucosa, mucosa membranes, mucous membrane, the nose, the mouth, the throat, the esophagus, the ET tube. Okay, yes. The catheter, the urethra. Okay, all these places are mucosa injuries. Devices that we put through those areas can cause trauma there. Yes, you are going to pass catheter. You have not seen urine coming out of the catheter. You are inflating the balloon. You will cause urethral rupture, and the patient will bleed, 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 bleed. You have caused mucosa injuries. Okay, you are going to pass NG tube. You did not lubricate the NG tube. You passed it. You are going to cause trauma to the mucosa lining. You are going to pass ET tube. You did not lubricate it. You are going to, every device that you introduce into the mucous membrane, you should lubricate the tip. Okay, yes. So because mucosa anatomy is different. When there is mucosa pressure injuries, you cannot see and what stage it. So if you don't know whether it is a big wound that you have created or a small wound, so you are going to cause. When do we delegate? Do we need delegation at all in wound? Do we need delegation with pressure injuries? Okay. Yes, to prevention of pressure injuries. Yes, the nurse must delegate. But we always say the basic rule is that if the patient is not safe, a patient who is unstable and not safe, we don't delegate. That's the basic rule. But the question is, do we need to delegate? Ayariga, will you delegate for a healthcare assistant to go and tend this patient? Which patient will you send them to? A healthcare assistant should go and tend a patient with spinal cord injury or what? So routine prevention measures for a stable patient, okay, may often be delegated to trained assistive, certified nurse assistant, not the nurse assistant who is not certified. Okay, we have two different types of healthcare assistants: certified CNA and the normal nurse assistant. He has not written any exam, so they don't know much about, but this guy knows well. Okay, so repositioning, the hygiene, the moisture care, and reporting skin changes. But the RN will always remain and retain the responsibility for any issue that happens. and any stage in assessment, whatever the ACPI, the RN is responsible. Okay. Sometimes NCLEX will come in and trap you that the UAP, the unassistive, unlicensed assistive personnel, okay, or the NA, unlicensed. Remember, we have licensed assistive personnel, the CNAs, certified, board certified. Then we have the unlicensed. Okay. The unlicensed assistive personnel reports that somebody's skin is purple. The UAP says that the patient he looks purple. Okay. Never ask the person what stage is it. They've not done any training. They were just employed by the hospital. Somebody finished high school. The hospital has employed them. They are working because the hospital needs staff. It did not do any training, not write any exam. You are going to ask this person stage of wound healing. Rubbish. Okay. The nurse, you should go and assess the patient. Because staging requires nursing judgment, clinical judgment is very important. Okay, Mr. Varys, I just saw your message. Okay, so let's try our hands on some questions here, guys. Yes, to refresh our memories on everything we have done. Okay, we have 15 minutes to go. So, an immobile patient, let me try and make it big a little. An immobile patient's sacral skin is intact but does not blanch when passed. How should the nurse interpret this question? This is a clinical judgment question. We did it this morning. So this alone should tell you what type of question is that. Clinical judgment question. So you should be able to know which type of clinical judgment question is this by answering the question for me. Question answer. Yes, shoot your answers. Tell me. Clinical judgment question. Yes. So an immobile patient's sacrum is intact but does not blanch when pressed. Okay. Yes. Answer. Shoot. Everybody should try and answer. Participate, please. Does not blanch when pressed. Good. Right. So this is stage one. Okay. Non-blanchable. Okay. If they write non-blanchable, you will know the answer. So this is stage one. Okay. Good. Then second question. A wound has visible subcutaneous adipose tissue. You should know the stage. But no visible fascia, muscle, tendon, cartilage, or bone. Which classification is most appropriate? Is it stage one, stage two, stage three, stage four? Good. Let's go. Visible subcutaneous tissue. It is barely asking you which layers will you remove before you see the adipose tissue. That is it. Let me make it simple for you. Which layers of the skin will you remove before you meet the fat and under the skin? Okay. So yes, if you are removing the layers, the first layer is the epi, the upper dermis. Okay, the epi, the upper dermis. Then the second layer is what? The dermis. Okay. Then the third layer is what? Is what? The adipose tissue, the fat. Okay. So if I am seeing this is stage one, stage two, stage three, C. Those who said C, they are right. Yes. Okay, Chioma, one is B, not A. Okay, one is B, not non-normal reactive redness. No, one is B. So we'll make that correction. Okay, right. Question number three. A pressure injury is completely covered with a thick black eschar. How should the nurse classify this? How should the nurse classify this? Yes, clinical judgment. If you want to pass NCLEX, clinical judgment should be your mattress and your pillow. You should always know your physiology. Okay. Before, did you know this? So it's good to always join class. Okay. Now the fourth question. The next, so this is an unstageable, okay, Escar unstageable. We can see the wound bed, okay, we can see the wound bed. So it is not stage four. People are choosing stage four. It's not stage four, please. It's D. So the nurse assesses intact dark maroon skin over the heel of an immobile patient. I'm reading again. The nurse assesses intact dark maroon skin over the heel of an immobile patient. What should the nurse suspect? Wow. Question number four. Yes. Dark maroon. These people. Oh, so funny. Yes. Good. Good. Yes. Yes. Good. Okay. Okay. Yes. Hey. Some people are saying D. Dark maroon. Okay. So some people are choosing D, some two are choosing B. Okay. So we all learned that this is a deep tissue. Okay. The skin is a mirror. So whatever is happening inside, if you see blisters, if you see dark maroon, okay, and all these sometimes with redness, okay, yes, redness, whether the skin is broken or not, something is happening down below, and this it is reflecting on the skin. So it's a deep tissue. We are suspecting what? Deep tissue pressure injury. Okay, good. Question number five. Shoot and let's go. Which intervention best reduces heel pressure in a high risk immobile patient? Which intervention best reduces heel pressure in a high risk immobile patient? Yes. Shoot your answer. Question number five. Question number five. Best. This is a comparative superlative question. Okay. So all of them will reduce the heel pressure, but which of them is the best? We see nurses doing all of this. And which of them is the best? Hoping for the best but expecting the worst. Yes. Uh-huh. Good. So you offload or float the heel off the bed. Okay. Question number 6. A post-operative abdominal patient coughs and says, something popped. Something popped. The nurse observed bowel protruding through the incision. Which action should occur first? Which action should occur first? This is what prioritizing hypothesis question. Prioritizing hypothesis question. Yes, shoot. Sarah, you're laughing at me. 6. Yeah, shoot. 6. Shoot. Mhm. 6. I'm watching your answers. Good. So 6, you cover the exposed tissue with a sterile saline moistened dressing. Okay. Cover the exposed tissue. Number 7, which patient should the nurse assess first? Assessment. So this one we are looking for what? The cues, recognizing cues. Okay. Which patient should the nurse assess first? Assessment, recognizing cue. Is this A, B, C, or D? Shoot. Question number 7. Shoot. Question number 7. If you are confused, use your amasa. You are gone. Okay. If you are confused, you can do your dual pairs or the pairs. Yes. Question number 7. When you people get questions like this, then you are happy. And when I give you tough questions, then my DM is flooded. Say, please, this question I could not do. Say, please, this question is tough. Say, please, this tomorrow. Tomorrow morning, 2 hours on clinical judgment questions. Come and test your strength if you think you are macho. So the slide I posted to you this morning, make sure you learn it tomorrow morning. Okay. Then afternoon session will be for the main group. If you are part of the main group and you want to join the morning session, you wake up early. Okay. Good. So question number 7. Good. A post-operative patient with rapidly increasing bright red drainage and blood pressure becoming 82/40. Okay. Question number 8. A nursing assistant reports that the patient's sacrum is red and wet. Okay, remember there is a statement in apostrophe. So it is either the answer or it leads you to the answer. The same strategy we use to answer IELTS. What should the RN do? So this is your, based on this, what should the RN do? What should the RN do? Question number 8. This is a cheap question. Oh, Senior David. That's how they do when the questions are cheap. That one they are not hear any report to. But when the questions are tough, then my ears will be breaking. As the questions are tough. Oh. The questions are this. I want you to sit on your bum and learn for me. Good. Anchors will never give you these cheap questions unless they are friendly with you. Okay. Yes, question number 8. Good. So you assess whether the injury is caused by pressure, moisture, friction, or another mechanism. Okay. Question number 9. A patient has a healing stage 4 pressure injury, but bone is no longer visible. How should the nurse describe this wound healing? Yes, seriously. And class is content based. Serious. So if your content is not good, that is why from Monday, come and let us chew content. We give you system by system analysis of medical conditions, system by system clinical conditions. We are starting a new journey. Don't be left out. Okay, before we used to do it in 3 months, but when we voted the last time, the 4 months people won. So it means in the space of 1 year, content, we are going to do it 4 months, 4 to finish the curriculum, to finish everything. Then, so if you are starting the journey, by the end of that 4 months, your ATT should be ready. And when you get your ATT, you now give yourself a month or two to prepare. You join the ATT class, prepare yourself, give yourself 1 month, 2 months, or 3 months. No rush, ATT stage, no rush, unless maybe your ATT is expiring, that you'll be in a rush to write exams. But for the 4 months content, make sure you complete it before you write your exams. Okay, good. So, question number 9. This is what a healing stage 4 wound. Okay, good. And question number 10. A JP drain. A JP drain produces 90 mils last shift on your last shift. This shift, there is no drainage, and the surgical site is becoming swollen and painful. Okay. The drain that is supposed to go to the JP drain is now accumulating around the surgical site, causing inflammation. Patient is complaining about pain. What should the nurse do? Question number 10. Shoot. What should the nurse do? Yes. What should the nurse do? What should the nurse do? What should the nurse do? Yes. What should the nurse do? What should the nurse do? Or what should the nurse suspect? What should the nurse suspect? Yes. So when you do questions like this, it refreshes your mind so that you'll not be bored. Okay. Good. We have 30 minutes to leave the line. Okay. So be aware. My life is in your hands. So be aware. Clinical judgment. Whether you like it or not, tomorrow I'm going to kill you with it. Question number 10. Oh God. Question number 10. I'm getting different answers. Why? Question number 10. Why? Don't you understand the question? Question number 10. I'm getting two different answers. Okay, so some are saying B, some are saying C, which is which? Okay, a 90 mil, you had it last shift. Okay, and there is no drainage. And the surgical site has become what? Swollen and painful. Okay, so it means that what? There is a bypass. The drain is supposed to come here to the JP drain. Yeah, but it is leaking to the surrounding tissues. Infiltration, we call it infiltration or infiltration. It is infiltrating into the surrounding tissues instead of coming to the drain. So what is causing that? It means that something is blocking this tube. That is why it is not coming. So fluid is what piling up here. Okay, and when it happens like that, it will start seeping or leaking into the surrounding tissues, into the interstitial spaces. Okay, that is why we are getting all this swelling and painful manifestation. So those of you who chose B, you are right. This is not a sign of dehydration. Okay, those of you who chose C, okay, understand your physiology well. Okay, good. You have all done well. Okay, you've all done well. We had some few challenges, answers, different answers, but okay. So I've added the master memory if you want to learn. Everything we have learned is here. So the master memory and the take homes. Okay. When you get the slide, take your time and go through. Okay, good. Now let's go to what? Part 7. So we are done with part 6. Part 7, we are going to do pain management, PCA, opioid, heat and cold application or compresses, sleep and non-pharmacological comfort. Okay, good. So, pain is a very big issue in NCLEX. Yes, it matters. But when pain meets airway issues, airway takes priority. When pain meets breathing problems take priority. When pain meets circulation problems, circulation takes priority. And immediate safety threats still come first before pain. Okay, yes. So we are going to learn all how to manage pain, the pharmacological and the non-pharmacological. Okay, so pain, me, I always describe pain that a tissue is dying, is dying, ing, is dying, in the process of dying. If tissues die, if they die, they finally die, you will not feel any pain. Okay, you will not feel any pain. That is it. But if they are in the process of dying, you will feel a lot of pain. If a tissue tears, you will feel what? A sudden pain. A sudden pain. A patient will say that I have never experienced this pain before. So somebody has what? A pregnant woman gets what? Ruptured uterus. The uterus tissue is torn. So patient will be complaining of what? Severe pain. A pregnant woman who has what? The placenta tears. Okay, it tears, abruptio, it tears. There's going to be sudden severe pain. Okay, yes, intestinal tears and all this one, rupture of an aneurysm. They are all tissues. Okay, yes. Somebody has chest pain. Okay, shortness of breath. The heart tissues are dying. Okay, yes. So we know our pain. Last week we did the how to assess pain, the PQRST or the OPQRST. Okay, of pain. Pain is subjective. So what will make me feel pain will not make Thomas feel pain. But patient has complained about pain. Should we take it serious or not? Yes, because everybody and their pain threshold. People has high threshold in a state in a state that we even have to implant a pain pump, a certain machine under their skin. And we put what pain medication in it. That will be pumping pain, the medication into their tissues to control pain. Yes, so that is pain pump. Okay, that means two patients can experience the same injury, and report different pain intensity. Some will say I have pain score of 10. Some will say I have 3. Yes. There are some pregnant women, when they are going to give birth, they will never cry, they will not shout. They will give birth and go home. We asked, did they not contract? The uterus, did they not contract? It contracted, but they have what? Lower threshold to pain. But some too will be crying, cursing every man on earth. Okay. Yes. That is what that is. They have high threshold. Okay. So for a patient who cannot communicate reliably, unconscious patient, a patient who is deaf, okay, and all these, they can't communicate. Okay. Yes, a patient who is having, so we use other methods to assess their pain. So a patient's self-report is the preferred indicator of pain. Yes, you can use so many assessment tools for pain. But if the patient tells you that this is my pain, that's the best that you should go. Okay. Do not decide that pain cannot be severe merely because the patient is smiling, merely because the patient is calm and watching television, merely because the patient is on his phone using it, or merely because the vital signs are stable, merely because the patient is not crying. They are feeling pain, just that they are enduring. So, pain skills are intended to help patients communicate their own experience. So, when you go to their room, children, we have faces. Okay, some faces smiling nicely, some faces weeping. Okay, some faces moody. Moody, like this. Moody is this. Okay, yes, the faces will show. Okay, or we have the numeric scale. Okay, to also show. So the pain trap. If patient A says, I have chronic back pain with 10 over 10, and patient B says, I have chest pressure with 5 over 10, we use the ABC algorithm. Two patients are complaining about pain. We ask them, on top of their pain, who has additional symptoms? Okay, this patient has what? The pain is coming from the origin, it's coming from the back. And this one, the origin is coming from the chest. So the back, the chest will come over what? The back. That is it. That is why when you are doing pain assessment, you do the OPQRST. Know your alphabet. Okay. So the origin, and the palliative or the cause, okay, the quality of the pain, the radiation, and all those stuffs. Okay, good. So pain assessment, oh, is yes. So the provocation or the palliation, what started it? Okay, or the origin, the old system they used to say OPQRST. So the origin, somebody is saying I have pain in my hand, somebody is saying I have pain in my head. Hand and head, whom should be seen first? The origin makes the difference. Then the provocation, what provoked the pain? What started the pain? What makes it worse? Okay, what makes it better? These are the questions you should know. So what started the pain? Ayarega slapped me and I'm having headache. So Ayarega is what started it. Okay. What makes the pain worse? When I shake my head like this, the pain intensifies. What makes the what makes it better? When I lie down, okay, the pain goes. Now, the quality of the pain, how do you describe? The patient should be able to describe the pain. Is it sharp? Is it aching? Is it discomfort? Is it blunt? Is it dull? Is it stabbing? Is it throbbing? Okay, yes. So all this description, is it electric for the nerves? Electric, like electric has shocked you, the nervous pains. Okay, yes. So all this quality the patient should. Then radiation. Where is it starting from and where is it rolling to? So somebody has come with what? A chest pain radiating to the shoulder. That should give you a clinical clue that you are dealing with what? MI or angina. Okay. Yes. So all these ones should tell you. Patient is having severe abdominal pain, sudden severe abdominal pain that is radiating to the back and the shoulders. That should tell you that what we have what aortic dissection or a ruptured any of the internal abdominal internal organs. Okay, good. Then the timing, when did it begin? Okay, is it constant? Is it intermittent or constant pain? Is it getting worse? When was the patient, what was the patient doing before it started? Okay, yes. So if you know this trick, which we did it last week, that's what I'm running through. If you know it, you should be able to hurt, understand, and how to, and it will help you a lot, especially those who work in the ER. Okay, yes. So what the U is under understanding, PQRST. Some say now even a lot of things. Okay, what does the patient think is causing the pain? The understanding of the pain. Okay, good. Don't do a long pain interview during an emergency. Emergency is after. The patient has come with what? Shortness of breath, respiratory failure. He's complaining of chest pain. You're not going to ask, is it radiating to this? When did it start? What were you doing before it started? No. In emergency, after assessment, quick. So, is the patient alert? Are they verbal? Is there any pain? Are they responsive or unresponsive? Okay, you are done. If you want to be upset, you do your GCS. Okay, but AFPU will finish first before GCS guy finishes. Okay, do not spend 10 minutes completing PQRST with an emergency. Emergency, you do your care before you come on document. So your ABC overrides pain. Okay, so that's it. So patient has come with acute pain. Where is the pain coming from? Is it from surgery, fracture, burns, kidney stones, okay, or gallbladder stones, acute myocardial ischemia, or trauma? So acute pain may and mostly stimulate the sympathetic nervous system. Okay, yes, the fight and the flight and the catecholamines, the fight and the flight and the cats, the catecholamines, cholamines. Is that how you spell it? Yes. So the adrenaline and the noradrenaline will be all over. The epi and the norepi will be all over in your blood. So dilated pupils, your heart racing, your hairs will be erected. Okay, your blood pressure up, your heart rate up, your respiratory rate up, everything because of pain. Okay, if you don't do anything about it, it can cause arrhythmias. Okay, arrhythmias. Yeah, so that is what you should know. So possible manifestations that the pain is affecting your catecholamines or the pain is affecting your sympathetic nervous system. Patient will start experiencing tachycardia, hypertension, arrhythmias, tachypnea, breathing fast, and diaphoresis, severe sweating, dilated pupils, anxiety. If you don't do anything about this and you don't calm the patient, de-escalate the patient, they will get what? SVT. No, they will get sinus tachy, okay, or VTAC, ventricular tachycardia. I have seen some before. My patient was complaining of pain, okay, and within a twinkle of an eye, he has become VTAC. Are you going to go through all this stress to reverse this rhythm? Or you are transferring the patient to the ICU for management. Okay. So these signs support your assessment. Okay. That's it. Somebody has chronic pain. Those guys too, how do you go with them? And arthritis, their waist, their knees, their joints, chronic pain. It does not go. Okay. Yes, sickle cell is what? Acute pain because you don't always have pain. It comes suddenly. Okay. But chronic arthritis, chronic neuropathy, the diabetics. Okay. Then later, when the nerves destroy, they will not even feel pain again. Sensation will be lost. Okay, then cancer related pain, people have chronic pain, so we put them on the Delodade, okay, the Oramorphs, and all those ones. Okay, then fibromyalgia. So patients may not display dramatic physiological response like those with chronic with acute. Chronic guys, some of them have learned to endure with their pain, especially cancer patients. Okay, so they are not dramatic. We will not see the sympathetic nervous system running all over. Sometimes their heart rate is normal, blood pressure is normal, calm appearance. That does not mean they are not going through pain. They are. Okay. Yes. So normal vital signs do not invalidate a patient's pain report. Okay, cool. We have 15 minutes to leave. Let's look at somatic pain. Somatic pain. Okay, somatic pain, skin related. So patients will come that have pain originating from the skin, the muscles. We have done skin, so you know when we say somatic, you know where you are coming from. Skin, muscles. It is genuine. This is not somatoform disorder. That a patient will come that I have muscle pain, I have bone pain, but you do your labs is negative. Okay. When you get somatoform disorder, it means your problem is becoming psychiatric. Okay. Yes, but some people have genuine somatic problems, pain. So skin pain, when you touch their skin, their body feels pain, generalized body pain. Okay. Muscle pain, bone pains, joint pains, like the sickle cell guys, somatic pains, okay, connective tissue pain, the tendons, the ligaments, the cartilages. It is often related to relatively well localized. So fracture can cause somatic pain, incision, arthritis, and muscle injury can cause that. So patient will be describing it as well. This is a sharp pain. I've not experienced it before. Aching, throbbing. Yes, this is soma. Now let's go to viscera. I've told you that when you say viscera, it's the internal organs. You can't see with your eyes. You have to cut deep, cross layers before you see them. So what if your liver is paining you? Or your pancreas is paining you. Somebody will come with what? Kidney pains, flank pains, bladder pain. Okay. Yes, these are what? Visceral organs. Okay. We have what? Lung pain. It comes from the internal organs. It is diffuse. Diffuse, like say the lungs filled with a lot of fluid, a lot of blood mixed together, okay, or fluid penetrating itself, getting itself into the pleural space, okay. If this is the lung and this is the pleural covering, this is the cavity, a lot of fluid is here. When the patient breathes in and the lungs expand, because the fluid is in the pleural, it will create a tension and a rubbing. So we call it the pleuritic chest pain. Okay, pleuritic chest pain. Yes. A patient is having what? A lot of fluid on around the heart. eh, with what that we do cardiosynthesis and all these ones. Okay, they also get rubbing pain when their heart contracts and relaxes, contracts. They get what? Rapid what? Pains. Yes. So all these things you should be able to know. Yes. So localized, poorly localized cramping, pressure like deep pains. So the visceral pains will come with what? I'm having abdominal, like the ladies, their pelvis, okay, the uterus, they are menstruating, cramping pain. Okay, I'm having cramps. Yes, that's a visceral pain. Okay, good. So the pressure like pain, okay, and deep pain. So somebody example, typical examples, bowel obstruction, gallbladder diseases, renal colic, intestinal distension, all these ones are there. Now let's look at what neuropathic pain that is coming from the nerves. Okay, sometimes somebody has cut, a doctor has cut, or somebody is doing some rigorous exercise and torn some of the nerves. Okay, severe nerve spetting, shooting. Okay, when you tear a nerve, when you tear an electrical wire, you see how the current runs through. Shoo, 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 shoo. That is what will happen, and that pain will be crazy for you. Okay. So the same thing happens. Our body is full of electrical wires. So you'll be having what? Burns, electric pain, shooting, shoo, 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 tingling. Like somebody is pulling your feet, your arms, tingling. Especially patients who have what? They vomit a lot and they have a severe electrolyte imbalance. If you see a cholera patient who is about to die, you see the pain that somebody is beating them, okay? Pins and needles are all there. Okay. So diabetic neuropathies, their nerves are destroying. Okay. So before the nerve will finally die, it will give you some serious pain. Okay, at the initial stage. But when the nerves die, that is where they can't feel sensation again. Even if there is a wound in their legs, they cannot feel it. So the wound will be what? Will be causing problems and they'll get infections and die. Okay. Prostapetic neuropathy and some spinal injury. Okay. So all these are what? Examples of what? Spinal issues. So patient says that I feel like electricity shooting down my leg. I should think about what neuropathic pain. Now let's look at referred pain, the types of pain, referred pain. So a referred pain is perceived in an area different from the actual source, different from the origin. Okay. So somebody has cardiac ischemia. I have a problem in my heart. The heart muscles are not getting blood. Okay. But there is a nerve here that connects the heart to what? To the shoulders or the jaws. Okay. Yes, definitely that electrical referral or the pain referral will be felt here. If we take the diaphragm like this, we have the phrenic nerve. One goes to the right shoulder, one goes to the left shoulder, and it comes together to at the neck and goes up. So if you don't feel the pain at your shoulder, you will feel it at your neck. When the diaphragm is hijacked, something splints the diaphragm like this and is not able to relax. Okay, somebody is having intestine, abdominal bleeding, and the blood has become plenty and is pushing against the diaphragm. Okay, the person will be having what? Back pain, and still then the nervous system, these phrenic nerves will be in trouble. Okay, yes. So do not assess only where the patient points. Ask, could this location represent pain referred from another organ? So always assess for referrals. Okay, always assess for referral. Now the pain scales. The pain scale should always match the patient's age, development, cognition, ability to think. Okay, a patient who is young cannot think. There are some pain scales you don't use for them. You ask them certain questions, they will not know the answer. A child who is 6 months old, you are going to use numerical scale. Can they talk? No. Okay. Communication ability is very important. So the common skills that we use worldwide is what? The NRS, numeric skills. We have the faces, okay, the facial appearance. Then we have what? The behavior, flag, the behavior. How is the person behaving with the pain he or she is going through? Your behavior, I'll look at your behavior and score you with the pain. You've not talked to me, but I'm scoring you. So let's take them one by one. The numeric, that's what a lot of people use, especially adults. So you give them a pain score of 0 to 10. With 0 means no pain, 5 means moderate, and 10 means severe, very severe. Okay, good. Then the patient will choose. Okay, good. Then we go to the faces. So the faces we have, if you click this, it will show you the one Baker faces. Okay, so different faces. Some faces smiling nicely, some face is weeping. Okay, some face is moody. So we use them for hot children. Eh? It is widely used with people age 3 and older. Age 3, toddlers, 3 to 6. 3 to 6 is what? Preschooler. Okay. Yes. And 1 to 3 is a toddler. So preschoolers. Anything below, you can use what? The faces. Do not look at the patient's facial expression and choose the face for them. Okay. The patient chooses. Yes, the patient, because preschoolers, they are able to what? Obey instructions, and they are able to communicate their feelings, okay, sometimes. So you are not going to look. This is not flag score, okay. Yes, so this is what you are going to do for them. So 3 years and above. Now let's go to the flag. This is a behavioral tool often used for patients who cannot reliably self-report their pain or communicate their pain. So I'm looking at you, an unconscious patient who has been intubated, who cannot talk. I can't, and the patient who is above 3 years, okay, or even below 3 years, okay. And look at the patient's face. Is he crying? Is he smiling? Is he moody? Is it this? Then I make my score. Look at the legs. Are the legs relaxed? Are the legs moving? Okay. Moving, like shaking the legs. You know, some women, when they are having pain, their legs will be moving. They can't even stand still and all this one. But this one is unconscious. So they will be shaking their legs and this, okay, the legs are not relaxed. I give my score. We have the score there. Then activity. What are they doing? Are they quiet lying down? Are they doing something? Are they walking up and down? All this, like the child. Okay. I assume. Then the baby, is he crying? Babies cannot talk. They communicate through crying. Okay. Are they crying? Is the patient crying? Is he tearing? Unconscious patient in the ICU. Is it tearing? A car accident patient who has come, patient is unconscious, woman, he is tearing. That patient, that's the sign of pain. Okay, yes. Then, are they consolable? When you talk to them, calm down. Your mother talks to them, calm down. Are they consolable? So the nurse observes their behavior rather than asking questions. Okay. If the patient can validly self-report generally takes priority over behavioral interpretation. Okay. Let's look at non-verbal patients. They cannot communicate. So you look at grimacing, guarding, okay, gnashing of teeth, rigidity, okay, arms, severe ones, mourning, restlessness, withdrawal, okay, agitation, change from baseline and physiological signs to know that, oh, this patient is in distress, pain distress, okay. Sometimes to rely on their patient, especially with the baseline. Are they like this? Were they like this in the home always? Or it is something that just happened? Okay. Then family member will say that, oh, they before they were not like that too. But about some week ago, they have started behaving this way. Oh, okay, this is a new what symptom. Okay, new onset of symptom. Dementia patients, can they also communicate their pain? Dementia does not mean they cannot talk. Okay, so a cognitively impaired patient can still experience significant pain. So dementia patient, you look for what? Resistance to care. You want to change their diaper, they say no, they are having sacral wound. Okay, you want to turn them in bed, they are having back wound, whatever wound, their hand is paining them. You hold them, they are what? They are in pain. Yes. So facial expression, they are guarding, decreased mobility. A patient, this is very, 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 very important. Okay, if you are working in care home, because some of them have unwitnessed falls. Okay, unwitnessed, and they will get up themselves and be walking around. But remember, they might have broken a hip. So with time, they cannot what weight bear again. So a dementia patient who used to walk around and enter everybody's room and wake them up, give them 1 day, 2 days, 24 hours, 48 hours, the pain will start becoming severe. And they cannot walk on their feet because their hip is fractured. Okay. So in the morning, we are waiting for them to come to the lounge to eat breakfast. They didn't come. They are sleeping. They are sleeping. They've slept the whole day. The next day, they are still sleeping in bed. Their body temperature is rising. Okay, take them to hospital, and the hospital will do all these X-rays, scans, CTs to know if they are having any problem and their blood workouts. Okay, yes, so that is what you should know. Do not automatically interpret agitation in demented patients as confusion. The patient may be in pain. Okay, so guys, our time is up. Tomorrow we start from 18. Okay. I've told you that I'm not going to spend more time. 3 hours in the afternoon, 2 hours in the morning, 5 hours a day. So tomorrow we shall continue with the pain journey. Okay. Good. Tomorrow, meet me here. Tomorrow morning, trial questions on what? Clinical judgment. Tomorrow afternoon, basic care and comfort. Remove. Thank you so much. Don't forget to like the page. Don't forget to like this session. Every session when you join, like it. Like it every session when you join. Like it. Like it every session when you join. Like it. Yes. Let me see you touch on the like. Sarah, touch on the like. Elizabeth, have you touched on the like? Touch it. Like the session. David, like it. When I mention your name, like it. Forrester, like today's session. Yes. Are you new here? Let me know if you are new. Yes, type I am new. Like it. Cynthia Potogbi. Like it. Cynthia Potogbi. I've not seen you here before. Are you new? Like the page. Like the session for today. Pfizer. Pfizer, are you there? Like it and let's go. Gloria Elemin. Like it and let's go. Yes. Like it. Hajara. Like it and let's go. Hajara. Okay. And happy. Like it. Chioma. Chioma, how are you? How are you, Chioma? Like it. Okay. Good. Naomi. Naomi Kwe. Like it. Like today's session. Yes. Let me see more likes. Patricia, are you there? I see you. Okay. Like today's session. Mary Sapoma. Like today's session. Yes. Like it. I want to see more likes. Ogochuku, are you there? Like it. Constance Boache. Ogochuku, I want to see your like. Constance Boache, like it. When you every session you join, like it. Okay. Yes. The way you somebody liked and somebody shared to you, you have to share this page to others. Okay. Yes. Vimsi Obeng, like it. Vimsi, how are you? You are a Kwewu girl. Obeng is Kwewu people. Yes. So you are a Kwewu girl. Gertrude Okwampa. Yes. Gertrude Okwampa. I like your surname. I had a classmate with that name. Ellen, like it and let's go. Sharp, like it. Yes. Thomas, like it. Yes. Tina, I have seen you. Like it. Okay. So if you are new here, this is the WhatsApp number. Okay. If you are new here, chat me and let's go. Like the page. Yes. Joanna, like it. Sewa Amofe. Wow. Like it. Sewa Amofe. Like it. Okay. So those of you who sent me message, I'll respond to all of you. Okay. If I'm sleeping, I'll throw my phone away, but I'll respond to all your messages. Okay. Yes. Patricia Pokua. Yes. Let me hear from you. Okay. Like what is going on. Like the page. Like it. Yes. Good. Florence Framer. Like it and let's go. Okay. Like it and let's go. So the main page, on the main page, when we are doing lectures, we go deep. But with the ATT page, they already know. Okay. You can't tell me you have your ATT, you don't know NCLEX, you don't know anything about it. It doesn't work like that. Because the process to get your ATT will take you more than 3 months. So don't wait to get your ATT before you start learning English. You are wasting time. Okay, you start it. Okay, yes. So guys, thank you so much. Okay, so our 3 hours is due. Thank you. God bless. Let me see any question. Please, those in the main page don't have the slide on clear. I posted it myself today. Frankie is there. Oh, those in the main page. Okay. Which page do you join? Are you part? Are you on our page at all? Okay. Maybe you are joining a different group. Oh. because I posted it personally to the page. So you should be having it. Okay. Josephine, how are you? Right. Thank you. Good. Thank you so much, guys. Bye bye. See you tomorrow morning. Bye.